Good morning, everyone, and welcome. I am Dr. Asim Hussein, and I am pleased to be here today to discuss endocrine and metabolic emergencies. Specifically, we will focus on the important topic of 3 adrenal crisis, or acute adrenal insufficiency. Over the next few minutes, we'll explore the key aspects of this critical condition, including its causes, symptoms, and management strategies. I'm glad you could join me, and I look forward to sharing this important information with you. All right, let's take a closer look at this case. We have a 54-year-old man with known Addison's disease, which is a primary adrenal insufficiency. He's presenting with vomiting, abdominal pain, confusion, a low blood pressure of 70/40, and laboratory findings showing a sodium level of 124, potassium of 6.2, and blood glucose of 3.1 mmol/L. These signs point towards an adrenal crisis, a severe complication of Addison's disease. The hypotension and dehydration from vomiting and electrolyte disturbances are classic features. The hyponatremia, hyperkalemia, and hypoglycemia are hallmark signs of adrenal crisis because the adrenal glands are not producing enough cortisol and aldosterone. The key here is understanding that Addison's disease can precipitate an adrenal crisis, especially during stress or illness. Recognizing these signs early is critical because this condition can rapidly become life-threatening. So, when you see a patient with known adrenal insufficiency presenting with these symptoms and labs, the most likely diagnosis is adrenal crisis. This is distinct from septic shock, hypovolemic shock, or other states, even though they may appear similar clinically. This highlights the importance of linking clinical history, presentation, and lab findings to arrive at the correct diagnosis in complex cases like this one. The correct answer for this case is B now. Let's break down why that is. An adrenal crisis is a serious medical emergency, and it presents with a specific set of signs and symptoms. Key features include hypotension, which means low blood pressure, and this can lead to shock if not treated promptly. In addition, patients often experience electrolyte imbalances such as hyponatremia, which is low sodium levels, and hyperkalemia, which is high potassium levels. Hypoglycemia, or low blood sugar, is also common, and all these issues can contribute to the patient's overall instability. What makes adrenal crisis particularly urgent is that these symptoms, especially the shock, don't improve with just fluid administration alone. If a patient is unresponsive to fluids, it indicates a more severe underlying problem, often related to adrenal insufficiency. Recognizing this pattern is crucial for prompt diagnosis and treatment. So, understanding these key features helps us identify adrenal crisis quickly, which is essential for initiating life-saving interventions. Now, let's look at this clinical scenario. We have a 39-year-old woman who has just undergone surgery and is now collapsing. Despite receiving 2 liters of IV saline, she remains hypotensive, which is quite concerning. Her medical history reveals long-term prednisolone use for SLE, and this detail is crucial because it points us toward a possible adrenal crisis. In cases like this, the immediate priority is to stabilize her hemodynamics and address the underlying cause. Given her background and current presentation, the most urgent intervention is to administer IV hydrocortisone immediately. This is because her symptoms suggest an adrenal insufficiency or crisis, which can be life-threatening if not treated promptly. Administering hydrocortisone quickly helps replace the deficient cortisol, which is essential for maintaining vascular tone and responding to stress. This intervention is time-sensitive and can be life-saving, especially in the context of possible adrenal crisis. So, in this scenario, the best immediate treatment is B, IV hydrocortisone immediately. This step is crucial and should be done without delay to improve her condition and prevent further deterioration. All right, the correct answer here is B now. It's really important to remember that we should not delay treatment while waiting for the ACTH test results. Time is critical in these situations. The appropriate course of action is to administer hydrocortisone immediately, specifically a 100 mg IV bolus. After that, we continue with a dosing schedule of 50 mg every 6 hours. This approach ensures that the patient gets prompt steroid coverage, which is vital for managing adrenal insufficiency effectively. So, always prioritize quick intervention to prevent deterioration, and then confirm with testing afterward. Let's take a closer look at this scenario. We have a 67-year-old man who might be experiencing an adrenal crisis. His sodium level is quite low at 120, indicating hyponatremia, and his potassium is elevated at 5.9. When approaching volume resuscitation in such a case, the key is to choose the fluid that best corrects the electrolyte imbalance while supporting circulatory volume. Now, considering the options, 0.9% saline, which is normal saline, is often the initial fluid of choice because it contains sodium and chloride in physiologic concentrations, helping to restore sodium levels and volume simultaneously. On the other hand, fluids like 5% dextrose alone don't provide sodium and can dilute serum sodium further, so they're less ideal initially. Balanced crystalloids, such as plasmolite, are also good options because they mimic plasma electrolyte composition. But in this specific acute setting, normal saline is typically preferred for initial volume resuscitation, especially when correcting hyponatremia. Hypertonic saline might be considered if the hyponatremia is severe and symptomatic, but it's used cautiously due to the risk of rapid sodium correction. So overall, for initial volume resuscitation in this patient with suspected adrenal crisis and hyponatremia, the best choice is 0.9% saline. The correct answer here is A now. Let's talk through why that's the best choice. Using 0.9% saline is effective because it rapidly corrects both volume depletion and hyponatremia. This solution helps restore the circulating blood volume while also normalizing sodium levels. It's particularly useful in acute settings where quick intervention is needed. Additionally, if the patient is hypoglycemic, we can add dextrose later on to address low blood sugar levels. The key takeaway is that 0.9% saline is versatile and effective in managing these issues promptly. This fits into our overall theme of selecting appropriate fluid therapy based on the patient's specific needs. All right, let's look at this question carefully. We have a patient with pneumonia who develops shock that doesn't respond to fluids or high doses of noradrenaline. That suggests we're dealing with a refractory shock, which is quite serious. Now, the lab results are crucial here. The sodium level is 128, which is low, so hyponatremia. Potassium is slightly elevated at 5.4, and glucose is low at 3.4. These electrolyte and glucose disturbances can give us important clues about the underlying cause. Given the context, pneumonia, refractory shock, hyponatremia, and hypoglycemia, one condition that fits this profile is an adrenal crisis. It's a critical scenario where the adrenal glands aren't producing enough cortisol, which can lead to refractory shock because cortisol is vital for maintaining vascular tone and blood pressure. This scenario aligns most closely with an adrenal crisis complicating critical illness. It's a reminder of how important the adrenal function is in shock states, especially when other signs point towards hormonal insufficiency. So, in summary, when we see a patient with pneumonia who develops shock unresponsive to usual treatments, along with electrolyte disturbances like hyponatremia and hypoglycemia, we should think about adrenal crisis as a possible diagnosis. The correct answer here is C now. Let's break down why that is. When we see a case of catecholamine-resistant shock accompanied by hyponatremia, hyperkalemia, and hypoglycemia, these clues point us toward adrenal insufficiency. Essentially, the adrenal glands aren't producing enough hormones, which can lead to these electrolyte imbalances and refractory shock. Recognizing this pattern is crucial because it guides us toward the right diagnosis and management. So, in the context of our overall discussion, understanding how hormonal deficiencies can present with these complex symptoms really emphasizes the importance of considering adrenal issues when the usual treatments aren't working. All right, let's look at this question about the best steroid choice in adrenal crisis. The key here is to identify which steroid provides both glucocorticoid and mineralocorticoid effects, which are crucial in managing adrenal crisis effectively. So, considering the options, dexamethasone, hydrocortisone, prednisolone, fludrocortisone only, and methylprednisolone, our main goal is to choose the one that covers both hormone needs. Dexamethasone, for example, is a potent glucocorticoid, but it lacks mineralocorticoid activity. Hydrocortisone, on the other hand, closely mimics natural cortisol and has both glucocorticoid and mineralocorticoid effects, making it ideal for adrenal crisis. Prednisolone also has strong glucocorticoid activity, but less mineralocorticoid effect. Methylprednisolone is mainly a glucocorticoid with minimal mineralocorticoid action, and fludrocortisone is primarily a mineralocorticoid, but alone, it doesn't address the glucocorticoid needs during crisis. Therefore, the best answer here is hydrocortisone. It provides a comprehensive replacement, covering both hormone deficiencies. This is why it's preferred in adrenal crisis management. The correct answer here is B now. Let's break down why. Hydrocortisone is unique because it provides adequate mineralocorticoid activity, which is crucial for maintaining electrolyte balance and blood pressure. This makes it particularly useful in conditions like adrenal insufficiency. In contrast, dexamethasone does not have significant mineralocorticoid effects, so it wouldn't be suitable when that activity is needed. Understanding these differences helps us choose the appropriate corticosteroid based on the specific clinical situation. This point ties back to our overall theme of selecting the right medication for the right purpose, ensuring effective and safe patient care. Let's take a closer look at the causes of adrenal crisis. One of the main causes is primary adrenal insufficiency, also known as Addison's disease, where the adrenal glands themselves are unable to produce enough hormones. Chronic steroid withdrawal is another cause. If someone has been on long-term steroids and suddenly stops, their body can't immediately adjust, leading to crisis. Sepsis or critical illness can also trigger adrenal crisis because severe infections put immense stress on the body, overwhelming the adrenal gland's ability to respond. Bilateral adrenal hemorrhage, which is sometimes called Waterhouse, Friedrichsen syndrome, involves bleeding into both adrenal glands and can cause rapid deterioration. Pituitary failure is another important cause. Since the pituitary gland controls adrenal function through ACTH, failure here means the adrenal glands don't get the signals they need. And finally, all of these factors can culminate in what we call an adrenal crisis, a life-threatening situation that requires immediate recognition and treatment. Understanding these causes helps us better anticipate and manage this critical condition. Let's discuss some of the key clinical features associated with adrenal crisis. When a patient is experiencing an adrenal crisis, they often present with shock that is unresponsive to fluids and vasopressors, which is a critical sign indicating that the underlying hormonal deficiency is severe. Hyponatremia, or low sodium levels, is also common, along with hyperkalemia, which is elevated potassium levels. These electrolyte imbalances reflect the disruption of adrenal function. Hypoglycemia, or low blood sugar, can occur as well, especially in severe cases. Patients may also experience abdominal pain and vomiting, which can sometimes be mistaken for other gastrointestinal issues, but are important clues in the context of adrenal insufficiency. As the crisis worsens, mental status changes such as confusion or even coma can develop, highlighting the severity of the condition. The term adrenal crisis itself encapsulates a life-threatening emergency that requires prompt recognition and treatment. Recognizing these clinical features early is crucial because they help us differentiate adrenal crisis from other causes of shock and metabolic disturbances, allowing for swift intervention and improved outcomes. Let's talk about emergency management in cases of adrenal crisis. First and foremost, administer hydrocortisone immediately. The typical dose is 100 milligrams given as an IV bolus, and then continue with 50 milligrams IV every 6 hours. It's crucial not to delay this treatment to perform an ACTH test because every moment counts in stabilizing the patient. Next, focus on fluid resuscitation. Start with 0.9% saline boluses to restore volume and maintain blood pressure. If the patient is hypoglycemic, add D5W to the fluids to correct blood sugar levels. Electrolyte management is also vital. If hyperkalemia is severe, treat it promptly to prevent cardiac complications. Hyponatremia should be corrected gradually. Rapid correction can lead to serious neurological issues. Finally, always look for and treat triggers such as infections, recent surgery, or stress, because these can precipitate or worsen an adrenal crisis. Recognizing and managing these elements quickly can make all the difference in patient outcomes. Now, let's go over some key points for ICU management. First, steroids often improve shock that is resistant to catecholamines. So, if a patient isn't responding to usual vasopressors, steroids can make a real difference. Next, regarding dexamethasone, it can be used, but only if we still need to perform an ACTH test. This is important because dexamethasone can interfere with the test results, so timing matters here. Also, if we're administering a high dose of hydrocortisone, there's no need to add fludrocortisone. The high-dose hydrocortisone already provides sufficient mineralocorticoid activity, simplifying the treatment. Finally, when we talk about adrenal crisis, it's critical to recognize it early and treat promptly, as it can be life-threatening. These points tie into the overall theme of effectively managing adrenal insufficiency and shock in critical care settings. Thank you so much for your time and attention today. I really appreciate your engagement and interest. I hope this presentation has given you valuable insights into the key topics we discussed. Remember, the main takeaway is how these concepts can be applied to make a positive impact in your work or projects. If you have any questions or want to dive deeper into any of the points, please feel free to reach out. Once again, thank you for being here and for your participation. I look forward to connecting again soon.